So today we are going to talk everything about PCOS and PCOD with Dr. Roya Rozati ma'am. Good afternoon ma'am, how are you?
Thank you, Aisha. Thank you very much. Yes, you are very right. It's a very important topic, PCOD, polycystic ovarian disease or polycystic ovarian syndrome, which is very, very prevalent and is up to, let's say, maybe about 15 to 20% of our young generation are having some kind of a polycystic ovarian disease. It is actually defined as the presence of a case with amenorrhea or polymenorrhea or irregular period, absence of the period associated with elevation of the male hormone associated with the presence of polycystic ovarian features on ultrasound transvaginal scanning. So there should be two criteria out of these three criteria. So I repeat again, either there should be amenorrhea and irregular period. The second criteria will be elevation of the male hormone like testosterone or the androstenedione, or ultrasound features of the polycystic ovary, yani peripherally placed small cyst, small follicles, preantral follicle up to 10 mm peripherally placed on the ovaries, which is diagnosed on the ultrasound. So two out of these criteria should be there. Then the patient will be labeled as a PCO. This is Rotterdam criteria 2003 criteria.
Okay.
So many doctors, MBBS doctors will label the young girls as a PCO. And frankly speaking, to a message to all the mothers and all the young generation, if any doctor tell you you have a PCO patient, do not believe. These three criteria, if it is there, two at least should be present. So make sure this is a correct diagnosis. Otherwise, you will label your daughter as a PCO, and then sometimes marriage problem, sometimes the psychological problem. It's not right to label a girl easily as a PCO. And the incidence is only up to 20%, 18 to 20%, according to the ICMR studies. There are categories. One is the severe type of a PCOD, where they are very obese, they are very hirsute, they have hair all over their face and all over their body, and their BMI is more than 30, 35. And there are type of a PCO where they are tall and their weight and their BMI is less than 25, hair growth is not there, they get a regular period, or sometimes they may get an irregular period. So let us categorize severe from the mild PCO. This is just to make you understand that if patient has a severe PCO, definitely she needs treatment. She needs to have weight loss. The lifestyle modification is mandatory. The diet modification is mandatory. Patient should be the girls, whether is young or little older age, they should be on a balanced diet, more green leafy vegetable, more high fiber diet, but the exercise, regular gym should be there, so that the BMI is maintained between 25 to 30 or at least below 25. If the patient, if the girl, the young girl, they have a BMI less than 25, so they are safe. Only thing what mothers should do and what the patient should do, should make sure that if she has got an irregular period, she must take tablets to get her period. The period, if it is missed more than 7 days, so then she has to take a tablet, because regularly if patient doesn't have period, so it will go on for a hormonal imbalance and the endometrial hyperplasia, and therefore endometrial cancer when she becomes 40, 45. And this hormone which is getting accumulated in her body, and then endometrial thickness is increasing, that by itself is contributing to more estrogen in her body, and this more estrogen in her body will contribute to more collection of the fat, because the lipid is also, there is a positive link between the estrogen and the lipid in the body, so more obesity will be there. So you must make sure the period should come. This is the first important instruction. Many girls, they will ask what investigation they should do. As I mentioned initially, first you have to check your LH. First you have to check your FSH to see these two are how much. Approximately FSH and LH 4 to 5. And in a non-PCO patient, FSH is more, but in a PCO patient, LH is more. And this should be checked on the second day of the period. The other thing which they have to check is the testosterone. This, if it is elevated around 10, 20, that by itself it will cause the production and this excessive growth of the hair on the face. If there are excessive growth on the face is there of the hair, this basically we can't do anything. The cosmetic approach is necessary, but to prevent further hair growth, then it is Dione 35 to be given. So first is a period which we give progesterone to get a period. Second is for the treatment of the hair growth, we give a Dione 35 from the 5th day for 21 days, which is got a cypertron acetate, which is a molecule which is antagonizing the testosterone. The third is a problem with infertility. Most of these mild cases of PCO, if they respond to clomiphene, that is the best. Clomiphene and also metformin. Glyphosate. Metformin is basically a hypoglycemic agent which is consuming most of the basically glycogen, the glucose, converting it to the glycogen inside the liver, and therefore these patients are maintained in a normal glycemic state, and also it is causing insulin sensitizing. Yani insulin, when it is secreted in the body of this girl, it will act very nicely and converting regularly the glucose, and it will be utilized. So then the obesity will be prevented. The metabolic imbalance which is created, it gets balanced. So glyphosate 500 mg before dinner is also necessary. Then myo-inositol is also very important to be given to these patients if they don't respond to clomiphene. We give 3 tablets or 2 tablets per day for 14 days. So this is also is going to help them for the ovulation induction. Approximately after 4 to 5 cycles of these cases of mild PCO with clomiphene, with the myo-inositol and with the metformin, they will respond, and maybe 60-70% they get pregnant. We are left with about 30% or 40% of severe cases of PCO, where if they are resistant cases and they do not respond to tablet and metformin, then they have to go for gonadotropin injection. And gonadotropin injection giving to these patients, it has to combine with in vitro fertilization and IVF process. The problem with these patients, their egg and their embryo is a granular because of high level of the insulin. Because LH has a positive feedback with the insulin, therefore it is increasing hyperinsulinemia state in the body, and there is a severe insulin resistance in their body. So whatever we give them, they don't respond. I had a patient, she was so massive, she was 135 kg, she was like a pillar. And when we give her any tablet progesterone also, she doesn't bleed. But ultimately with the expert handling, we had to make her bleed. We induce her with a high dose of the gonadotropin, and then we developed good eggs, metaphase 2 egg, at least 10 egg we have to have, and then we did the in vitro and ICSI, we do ICSI nowadays, and then we developed good blastocyst and transfer her in a segmented IVF, and she is blessed with a baby boy, and now the life is made. What I mean to say, there is a skilled expert handling is very mandatory for these challenging cases of PCO, because sometimes results are very disappointing. So patient, they put a lot of money for gonadotropin, for in vitro and ICSI. So we should be familiar, and we should be expert enough and experienced enough to deal these cases on correct time. Thank you very much.